off. So as we were saying, if you have sodium and potassium in different compartments of the cell, so meaning either mostly inside, mostly outside, then you're going to have them move in a direction down their concentration gradient, right? So we know that sodium, so if we just kind of draw a basic cell here, right? So here's a cell. If we know that sodium is primarily outside the cell, and we know that potassium is primarily inside the cell, right? Well, we know that when sodium channels open, sodium is going to rush in, and we know that when potassium channels open, potassium is going to rush out, right? So that's exactly what we see over here when we look at our graph, right? We know that sodium influx, right? We know that sodium influx is sodium moving into the cell, what's going to increase the membrane potential. And so we see that depolarization phase, right? When we have potassium, right? So now when we have potassium channels open and potassium is leaving the cell, well, we know that potassium has a positive charge, it's leaving the cell, and it's going to make the membrane potential more like its own equilibrium potential, okay? And what that's saying is that it's essentially making the membrane potential more negative, right? So we see this falling phase whenever we have potassium leaving the cell, right? So that falling phase, we'll write over here our second major event. This is called repolarization, right? Repolarization, essentially meaning we're reestablishing the polarity, right? So at first we were depolarizing, we were increasing the potential, and then we bring it back down and we decrease the membrane potential back down to our baseline somewhere around -60, right? And that sequence of events, right, that sequence of events from the pacemaker potential to the depolarization phase to the repolarization phase, right, each of those, that's contributing to one heart beat, right, one heart contraction, okay? And so we said that if you take this number 1 and 2, right? So if we take these numbers 1 and 2, 1 and 2, and we move them further apart, right? That's going to do something to the heart rate. And if you move them closer together, that's going to do something else to the heart rate, right? So one way to think about this is to think about what things in the body, right? What systems, medications, drugs, hormones, neurotransmitters, whatever, what things could potentially cause number 1 and number 2 to move closer together, right? What is something that could potentially cause that, right? Well, if we're thinking about it from a systems perspective, right? So if we think about it from a physiological perspective, one thing that we may have, and I'll write it here in this color here, is think about the autonomic nervous system, right? So what is the autonomic nervous system doing, right? Or what are its divisions, right? Well, one, we know we have the sympathetic division, but we also have the parasympathetic, right? So remember, these systems are, and we're not going to go into all the details of the autonomic nervous system, but these are largely antagonistic to each other, right? So meaning sympathetic causes the heart to do one thing, and parasympathetic causes the heart to do largely the exact opposite, right? So if we're talking about heart rate, right, well, we know that sympathetic causes an increased heart rate, right? Whereas if we talk about parasympathetic, this is going to cause a decreased heart rate, right? If you were talking about blood pressure, sympathetic would increase blood pressure, parasympathetic would decrease blood pressure. If you're talking about digestive activity, sympathetic would decrease digestive activity, but parasympathetic would increase digestive activity, right? So this is our fight or flight system, right, with the sympathetic, and our rest and digest with the parasympathetic, right? But if we stay here talking about our heart rate, right, what our sympathetic nervous system is doing in context of talking about the pacemaker potential is it is increasing the permeability of these SA nodal autorhythmic cells. It's increasing their permeability to sodium and calcium, right? So if we can increase the rate at which sodium comes into the cell and calcium comes into the cell, then we're making our pacemaker potential and that first depolarization phase, we're making that happen much more quickly, right? So again, if we were to draw another graph here, right? So if we were to draw another graph, okay, so here's another graph, and we draw, and I'm not going to draw all of it, but instead of having a very shallow increase, right, in the pacemaker potential and the depolarization, maybe we have a much more acute, right? So I'll draw it in a different color. So maybe it comes up to here, and we get this occurring much more quickly, right? So notice here in the blue, we reached our threshold, right? So maybe we say our threshold is somewhere around here, right? We reached our threshold a little bit faster with um, with the blue graph, right? So under sympathetic innervation than we did with the red, which is maybe no sympathetic, right? Under normal no sympathetic activity, right? So again, you could make boundaries, right? So we can say here is where both of our graphs start, right? Here is where the sympathetic graph or the one under sympathetic innervation, that's where it ends. But if we look at where our normal one ends, it ends a little bit further down, right? So we know that we are further apart, right? So if we label these, so we'll say this is number 1, this is number 2, and this is number 3. The distance between 1 and 2 is shorter than the distance between 1 and 3, right? So the question I asked you earlier, 1 and 2, those are closer together. We shortened the distance, right? So again, if we go back up here and we think about this number 1 here and this number 2 here, we've shortened that distance, so we've increased the heart rate, right? So we've increased the heart rate. Whenever we stretch it out and we go from number 1, so if we come back here and we go from number 1 to number 3, right? Now we've lengthened those two events and we've decreased the heart rate, right? We've slowed the heart rate down just a little bit, right? And so that would be what would happen under parasympathetic control, right? So if we come back over here and we think about parasympathetic, right? The major neurotransmitter that we're talking about with parasympathetic, this is going to be something called acetylcholine. And when we're talking about it with sympathetic, the major neurotransmitter is something called epinephrine. You may have heard it called adrenaline, right? Adrenaline. But both of these are acting on their respective channels in the SA nodal, these autorhythmic cells, to either increase or decrease the rate at which these pacemaker potentials occur, right? So in the case of the acetylcholine and the parasympathetic activity, right, the acetylcholine is essentially decreasing the permeability to maybe sodium and calcium, but it's increasing the permeability for potassium. So essentially the cell is going to be more hyperpolarized, right? It's going to start at a more negative value and thus make it more difficult for the cell to reach threshold, which means that this pacemaker potential is going to take a little bit longer to reach threshold and thus is going to slow the heart rate down, right? So if you are in a hospital setting, clinical setting, and you are on a certain medication that is either affecting your heart rate to cause it to increase or decrease, these are called chronotropic, and I'll write it here in the middle. These are called chronotropic agents, right? Chronotropic agents. And these can be either positive or they can be negative, meaning they're increasing the heart rate, a positive chronotropic agent, or they're decreasing the heart rate, a negative chronotropic agent, right? So think about these different ways that you can affect this pacemaker potential with various types of drugs, medications, neurotransmitters, and hormones.